I'm here as co-chair of the AORTIC Education and Training Committee. This committee has been there for a long time, but since 2014, it's been much more active, bringing you a lot of sessions and also bringing you a lot of activities, including our faculty development workshop in the last AORTIC conference. And so here today we're coming to discuss knowledge production. This is the Africa at ASCO. We know that ASCO and ESMO are powerful organizations. Their conferences are the major events in which we are eager to engage. And recently, these organizations have shown some interest in us engaging with their platforms. We still see a lot about us without us, where people from high-income countries or those who have little engagement in Africa are the ones in the podium talking about us. But this is not the reason we are here today. The main reason for having this webinar is to examine our engagement in the global platforms, in these global platforms, with the central question being, are we active participants presenting the knowledge we have produced, or are we passive consumers of knowledge produced elsewhere? So the goal is to look at our range of activities in these conferences, engage with what we presented there, and also take the opportunity to encourage research and critical inquiry. And this is not the first time we have done this activity at the Education and Training Committee. If you go to the AORTIC Africa YouTube channel, you will find that Shil, Fidel, and Miriam had come through the African abstract presented at ASCO 2020 and discussed them in some detail in a very lively video. Unfortunately, we were not able to do this in 2021, but we are now going back to that tradition. This time around, we are asking the abstract presenters themselves to tell us about their work. We hope to learn from them and to encourage more research from Africa, and they can also, hopefully, they'll tell us about the challenges and the times in the process of producing that piece of knowledge. We aim to change the status quo of Africa, of what we call Africa 2015-25 reality. And by that, I mean that 15% of the global population lives in Africa. 25% of the global disease burden is in Africa, while only 2% of the world research output is produced in Africa. It's not as gloomy as this may seem, because despite low research production in sub-Saharan Africa, there is significant research activity and exchange of ideas, especially in the last few years. Part of it is because of technology, and part of it is because we are now having a critical mass of young people, as we are seeing today, that are, there's a lot of dissemination of ideas, including local conferences, local journals, the gray literature. You simply join the WhatsApp groups of clinicians of various cancer society. Example is AORTIC conference, that the virtual one, the abstract, there were about 400 abstracts of very actually high quality, and that address matters what matters in our local setting. They may not be published research, but that's something else that we need to discuss as we go in the process of our activities in the Education and Training Committee. I will stop here and hand it over to you guys to present the program. And thank you so much for being here today.
Thank you, Dr. Nazik, and thank you for everyone who have joined. I see we are about 46. Thank you for everyone who have joined the meeting. Thank you for a wonderful introduction of all about this, and you've made it easy for us, really. So my name is Dr. Ashil Manirakiza. I am a clinical oncologist at the King Faisal Hospital in Kigali, Rwanda. I am a moderator today, along with Dr. Melinda Mushonga, who is also a trained clinical oncologist, who is currently in Canada. I just got to know about today, but she practices oncology at the Pararenyatta Hospital in Zimbabwe. So the reason why you're here, Dr. Nazik have talked about it, but I'd like to go on a little bit about how the themes were chosen, the type of research that we're speaking about today, Sorry, you'll hear background noise. I'm in a typical African family. You'll hear children crying, but anyway. So the themes today is all about oncology leadership, female representation in oncology. We'll speak about the care systems readiness in cancer care, and also how the pandemic of COVID-19 has come about and how it has shaken our systems, our cancer care systems. We'll speak about the challenges and value in cancer care and also outcomes research. So we've tried to subdivide the sessions into two. I'll take up the first part, which is mostly this introduction part, and the leadership in oncology, female representation part, and also the outcomes research. Dr. Melinda will speak about, the COVID-19 pediatric cancers and value in cancer care. So the themes were chosen mainly after screening all, the abstracts that were chosen, that were spoken and presented at ASCO in beginning of June this year. And so the idea was to choose mainly things that were done by Africans. So any first author that is African and who presented at the ASCO was spoke or approached essentially, and also anything that involved Africans, anything that involved authors from Africa and research done in Africa was also picked up. So without further ado, I'd like to introduce, there is no prof today, but Dr. Mutebi, who is an assistant professor, surgeon at the Aga Khan University and Hospital in Nairobi, and who is the current president-elect at the AORTIC organization. She will speak about the leadership in oncology and female representation, regarding an abstract and poster that she presented at the ASCO this year. Welcome, Dr. Mutebi.
Thank you so much, Achille. I'm going to try and share my screen. Sorry. Can you see my screen okay?
Yes, we can. Just as a quick one, we have 10 minutes per speaker.
Okay.
So let's try to abide by that. It's a Friday evening in Africa. Thank you.
Noted. I'll try and be extremely brief, but thank you for the opportunity to share briefly about our oral presentation and reference a little about the abstract as well. And so over the next few minutes, we'd really want to just touch a little about the challenges and opportunities facing female oncologists in sub-Saharan Africa, but really perhaps my emphasis is probably going to be more around the opportunities. We do know that women play a critical role in the health workforce, with over 70% of the global health workforce being female, but then this doesn't necessarily translate into leadership positions. And we have seen quite a number of articles by ASCO and ESMO really highlighting challenges facing female oncologists in different parts of the world. However, really the experience in most of sub-Saharan Africa is largely unknown. And so as part of the initiative by the Education and Training Committee, we set out to determine what the substantial challenges were for female oncologists on the continent, but really looking more at what are the identifiable potential solutions that we could employ. And so we had a multidisciplinary panel of about 32 female oncologists, really at different career stages from 20 countries in sub-Saharan Africa. And after, sort of have a brief meeting around looking at different terminologies, had a modified Delphi three-round process that really aimed to look at, one, what the challenges were, but more importantly, what the opportunities were. And so our participant demographics showed mostly from mid-career, which is about 5 to 15 years, late, which is more than 15 years, and a few early career oncologists, and really looking at the representation across different parts of Africa, East, West, North, and Southern Africa were fairly well represented. And what we encouraged the participants to do was really reflect on their experiences, consolidate that into what they felt the top challenges were, and then really think creatively around what the potential solutions to addressing these were as well. And so this ultimately ended up having at least a set of 3 focus groups in total. And our responses were fairly reasonable. I mean, we had about, at least for the initial rounds, at least more than 2/3 presentation. But what we found was the greatest challenge was the pressure to maintain a work-life balance. This contrasted by the social obligations that many of the participants felt were unique to the African context. Our strength is our community, and we're at every wedding, perhaps funeral, or whatever significant social event that's going on. But really, the role of women is quite heavy in these tasks, and so that was felt to be the top challenge amongst women oncologists. Again, this was followed closely behind by a lack of female support and networks, workplace microaggressions, and really a lack of leadership and opportunities and mentors. Not surprising was the solutions with the greatest resonance was increasing mentorship opportunities and increasing flexibility of working arrangements for mothers where possible. So just to give you a sense of the top challenges that we had, we talked about work-life balance, lack of mentorship and support, really lack of access to support as well in terms of infrastructure to conduct research, leadership and management support, and really looking at through the solutions. Mentorship was really top, looking at how we can advocate for external funders to support researchers in low and middle income countries. A recent article by The Guardian, probably about 2 weeks ago, really underscored the need to develop female scientists in sub-Saharan Africa and how they're really leading the charge on that. And looking at how do we provide not just adequate maternity leave, but parental leave for family emergencies, and developing an international network of mentors for women in oncology. So when looking at this challenge, we're not just looking at women, increasing women for women's sake, but we're looking at what is a triple, as Dr. Rupa Dutt refers to, what is the triple benefit or triple dividend that we're seeing? And so we tried to look at the lens, both our thematic analysis through the socio-ecological model, and look at what are the things at an individual level, interpersonal level, community level, and societal level that we could attempt to address and define. And so in terms of the challenges, of course, we talked about the work-life balance, personality traits, things like imposter syndrome, and then looking at the interpersonal level, how we engage in the workplace, what is our collegiality amongst different genders, is there female competition, and then looking at the community, how do we perceive our women oncologists, and what are the barriers that exist towards access to leadership positions. And then, of course, really coming down to not just how we perceive our women oncologists, it's how we perceive our women in the society, and what are the structures that we're making to provide an equitable workforce. And so just to give you a sense of some of the challenges people were talking about, somebody just talked about an individual work-life balance and saying she only had a baby in her 30s and she wasn't able to get another one. And so really perhaps if she decided not to have a child, she may have been a professor by now, really talking to the maternity penalty that women frequently face, microaggressions where you're at a meeting and somebody was saying they would call everyone by their professional, but then maybe address that particular individual by their first names, and then barriers to leadership, why women are not necessarily being brought forward for promotion, and then looking at the resources that yes, some of these challenges are germane to working in low and middle income countries, but really looking at perhaps the lived experience by women is different just because of the considerable additional social burden that they take on. Again, in terms of really looking at the solutions, it's again thinking about how do we at that individual level empower this female oncologist, give her the skills development, increase the mentorship opportunities from an interpersonal level, really looking at how we all can work together to build an equitable workforce, because it's a win for the system if we are having more flexi time, if we're having more respect, and we're actually helping to expand how many women are operating in the health system in leadership positions. And again, from societal perspectives, really creating an enabling workforce environment. And so some of the quotes really are circling back to what we talked about, increasing our mentorship opportunities, really celebrating the identity and value of female oncologists. And I'll be specific to this because we do know that women do have the potential and are actually involved in mitigating some of the barriers to care. Our oncologists really talked about their role in perhaps enhancing respectful care for patients and having counseling patients and having them sometimes, agree to have a mastectomy, which they had, previously declined. So really in those nuances in terms of helping to support and enhance the overall care provision. And so I think I would say our key findings are women oncologists serve unique roles in the health ecosystem. And I think it's important for us to think of it as a systems approach. We're not just investing in women, we're looking at how do we have the development dividend by expanding the workforce and economic opportunities as growth. By improving the gender dividend, you are improving nutrition, education, and by extension, women's empowerment and engagement. And that does have implications in terms of women's health and child health improvement. Again, looking at the economic dividends, where we're talking about how do we achieve the 2030 sustainable development goals of, the full participation of women and the aim towards universal health coverage and adequate at least adequate workforce. We still are having a deficit of 18 million jobs that we do need by 2030 in order to improve that. And so we did see that female oncologists did have different challenges along the entire socio-ecological model. But I think, as we said, some of these challenges were not gender specific, but really perhaps the lived experience painted a different light on them. But I think the take home should be there are many potential solutions that we can all work together towards that we can do to implement and address these existing challenges. And so as part of our recommendations, we are appealing to strengthen the newly established African Female Oncologist Task Force. And this is not just a women-specific thing. We need allies, we need support from the entire oncology workforce. And we're hoping that this task force will engage in regular meetings and projects, which will aim at delivering solutions that arose as part of the challenges highlighted in this project. And perhaps looking at a set of where we're able to develop a robust communities of practice such that we're able to have a workforce and the development of female-to-female mentorship and collaborative projects. And so I would say female oncologists are happy to work with the entire workforce and are eager to expand their role. And I think there's potential solutions that we should all creatively think about towards developing enabling workplace and policies in place. I'd just like to thank AORTIC, the Education and Training Committee, the African Female Oncologist Task Force, and the Queen's University Global Oncology Department, and my institution, the Aga Khan, for the opportunity to share this with you all. Thank you.
Thank you, Dr. Mutebi. This was very concise. Thank you for keeping time. We're open for questions. We have about 9 minutes for questions. It can be through chat. It can be, raising a hand and asking a few questions. I don't know if there is any right now that is pressing. Anyone? Thank you. So my few questions really regard promotion. Perhaps that you've gone, to participants who have a good way of promoting. So some other systems around, even ours actually, do not necessarily go through the usual university grading and promotion. So how does that happen? Is it grading from, say, junior consultant to senior consultant? Is it more responsibility and leadership? How do they define promotion? Because I guess it's not, similar everywhere.
Yeah. Great question, Ashil. And I think that's been part of the problem with many of our academic institutions, because most of the academic institutions have a rudimentary way of promotion criteria, but what you find is it tends to be very operator dependent and with lots of goal shifting. So, they say do X number of publications and you can achieve that. And as soon as you achieve that, they're like, no, actually you need to be doing more of your clinical work and that kind of thing. So it's really about how do we define, even as a academic community, what are the metrics that we're employing and what are the things that we're putting in place in system, because it's really disrupting systems and looking at how do we best place our academic individuals in a position to best support academic output. We're saying we do want you to, produce X number of research, but what things are you putting in place to support us to be able to do that research? I can't be, seeing maybe crazy clinics until maybe 8, 9 o'clock, and then being expected to do the research in my spare time. Or you're the one still, as you know, Ashil, working on the continent, you're the one who's maybe coordinating the flow of patients. You're the one who then subsequently has to follow up their lab results or whatever. And so it's looking at how do we develop efficient ways of generating or care delivery, but still within that, embedding research, the research culture into that, that's actually going to be able to support our academic output. Prof. Hamad talked about, research done, talks about research done, about us, but not with us on the table. But if we don't have the time or are simply exhausted to participate, then that's a real concern that we do need to start taking seriously. I think Prof. Williams has his hand up, I think.
Yeah. Go on, please. You're muted, actually. While he's working on his audio, there is a question that you were asked by Haimanot Kasahun. So the question is, how do you think we solve mentioned challenges of women in oncology in short and long run? I don't know if you have a quick answer to that.
Sure. Thanks, Haimanot. And it's pretty much really going down that socio-ecological, do that short term, set up networks, set up collaborations in which to engage. At the interpersonal level, it's really getting all our allies on board to sort of think about how do we create a conducive workspace, but then really taking that to the next level, which is a long-term goal about how do we disrupt our systems? How do we create structures that actually help to provide equitable access to resources and support for all faculty that will ultimately end up improving our output as clinicians and healthcare providers on the continent. So that would be how I would sort of look at it. The sort of interpersonal are easy to solve, but then the rest would be long-term. Thanks.
Mm-hmm. So there is a question that came regarding, IGCS has a gender neutral council and committees. What about AORTIC? I think you're best placed to respond to this again.
In terms of gender neutrality, I think the balance has tipped because we have a predominance of female representation and that's part of the other poster abstract that we presented. So we are definitely seeing more female engagement on the boards and representation in sub-Saharan Africa, which is exciting. So perhaps there's opportunities for shared learning and engagement with different societies across the board and sort of seeing what we can learn from each other. But we're happy to report that there's definitely quite a considerable representation, at least on our boards. Thanks.
And another question is about if you think the challenges are specific for oncology disciplines, and if yes, why?
Thanks for the question. Of course, these challenges are, I would say, a little more germane because you find that as an academic working in sub-Saharan Africa, you are definitely going to encounter challenges of resource, low resources, and so it's not necessarily unique to say oncology only. I think this is cuts across the entire workforce. As we said, the lived experience and additional responsibilities for women in sub-Saharan Africa may skew that burden a little heavier as per our findings, but it's definite, and that's why we're saying it's not just the women's argument. Even in terms of the solutions, we're looking at how do we get the entire workforce to the level where we're having better output and better engagement and research around our patients that actually impacts their care. Yeah.
I don't know if there is any other pressing question. I still see the hand of Prof. Christopher up. I've tried to ask him to send the question in a chat box, but he hasn't. But for the few years I've spent around AORTIC, I'm proud to say that AORTIC is really driven by women. And they are many of our mentors, and I'm proud of the men that do not have toxic masculinity around AORTIC, who let the women drive and lead, really. Yeah. So we are at the end of our first part. Thank you so much, Dr. Mutebi, for your talk. If there is any other question, I'm happy to receive them and direct them to Dr. Mutebi as well. The next part is outcomes research. We have 2 papers lined up. We have one by Dr. Atara Azayan-Tekim and also by Chimwemwe Banda. One is from Nigeria and the other from Zimbabwe. We're going to start with the one in Nigeria, looking at HER2 positive breast cancer patient and essentially looking at assessing the response from docetaxel and trastuzumab for these women in this condition. If you're ready, Dr. Atara Azayan-Tekim, please take it up. Thank you.
Yes, good day, everyone. Please, can you see my screen?
So we can see that you've started to share, but we can't see the screen yet. Okay, now we can see. Please, just a reminder that you have 10 minutes. After that, we will have the other speaker as well. Thank you.
Yeah, so good day, everyone. My name is Atara Azayan-Tekim. I'm a radiation and clinical oncologist with the University of Ibadan in Nigeria. Thank you very much for this opportunity to share some of the works that we are doing. Now, I have a very small conflict of interest. This research was actually has the support of Roche, but they are not the main sponsors. So it's an investigator-initiated project, so they just gave us the support. So the views here are not from Roche. Now, our study is a clinical trial. This is based on the fact that there's a low level of cancer clinical trials in Nigeria and sub-Saharan Africa. So a lot of people have been concerned about it, and there have been several efforts that have been put in place to try to improve the situation. As part of our own efforts, we decided to see how the trend could be reversed so that our patients could always be part of clinical trials that lead to the approval of medications that are made for cancer globally. And so we started by assessing ourselves and looking at why we were not competent, let me put it so, not to partake in clinical trials. And then we did some assessments, site assessments. Then there were some discoveries that we had facilities were not optimal. And then the trainings that we had were not actually what could actually enable us to do that. And so we had several collaborations to be able to improve the situation in terms of training and upgrade of infrastructure, both internationally and locally. Now, this was actually led by the University of Chicago Center for Global Health, led by Professor Fumi Olopade. Now, the ARETA study is actually a phase 2 investigator-initiated study. It's a very simple protocol which we designed so that we can be able to implement it successfully. Now, it is actually a trial in progress, and that is what we presented at ASCO, because the trial is still ongoing. The data is not yet mature, and so we just want to let you know what we are doing. Now, the objective of this trial is to examine what proportion of patients will achieve complete clinical response with the docetaxel and sulfonylureas accepting in order to be able to spare the toxicity associated with polychemotherapy. It also has the objective of the fact that at the end of the study, we can also do some exploratory studies to discover the markers of response and resistance to this regimen. And more importantly, it represents a feasibility project because we haven't done a major clinical trial before. And so we wanted to test run our team and facilities on how to conduct this trial. 4 centers are currently involved in the study. At the University of College Hospital in Ibadan, Lagos State University Teaching Hospital, and Lagos State University Teaching Hospital, all in Lagos, Nigeria. And then the Obafemi Awolowo University Teaching Hospital in Ile-Ife. The study has a very simple scheme, as I said before, so that we'll be able to operate it. Actually, it involves women with early and locally advanced breast cancer, that's stages 2A and C. Now, these women will be screened, but they have to have 2 positive tumors. And of course, the important thing is that we have to be able to assess their basic cardiac status, and then as well as the minimum breast lesion that they have. The minimum breast lesion has to be at least 2 cm so that we'll be able to monitor the progress with the therapy. Now, the patient will receive 4 doses of docetaxel neoadjuvantly with Herceptin. Then after 4 courses, they will undergo a repeat ultrasound to measure the response. If there is complete clinical response, that is based on the ultrasound measurement of the breast lesion, the patient will now go on to have surgery and then complete a trastuzumab to complete 18 doses. Now, where there is a residual disease after the second ultrasound assessment, then the patient will go ahead to have a combination of FEC, that is 5-fluorouracil, epirubicin, and cyclophosphamide for 3 courses. And then they go for a repeat ultrasound. If there's a complete response, they'll go for surgery. If they see residual disease, they'll still go for surgery and then continue for Herceptin to complete 18 doses. Now we have an entry criteria. The patient will be aged 18 to 70 years. And then of course, the tumor has to be biopsy accessible from 2 cm. And then at the end of the chemotherapy, we also have a test from the mastectomy or breast surgical specimen to be able to assess what response has been, whether it's complete response or pathological complete response. Now, the status is that the study started on 3rd April 2020, and as at now, we have 43 out of the plan for the 7 evaluable patients that have been enrolled. Now, so far, there has been regular monitoring visits, and then regulatory visits as well, and all the reports very constantly, and everything has been going on well. Now, the Data and Safety Monitoring Committee last reviewed the trial results in February this year, and then they suggested that the trial should continue as planned. Now, we have some successes and some challenges that we would like to share. Now, it's interesting to note that most of our patients attend clinic, have a clinic attendance of almost 95%. This was quite surprising because we know that in this part of the world, clinic attendance is always very low. And so because we anticipated that, so we had to put some measures to ensure that the clinic attendance improve. And this was through the employment of study navigators to be able to guide these patients whenever they come to the hospital. They don't waste time. They take them to all the nooks and crannies or wherever they want to do their tests very easily. Then we also had to employ some psycho-oncologists who are part of our team to monitor those patients very closely and then encourage them. And so with that, we were able to achieve very good clinical attendance, which was very good for the study. Now, so far, we haven't had any major protocol deviations, nor safety or logistic issues. A lot of people who have involved in the trial have been very, very hardworking and making sure that things come up on time and then things are going on well. And there has been no serious adverse events from the study to warrant stopping the trial. Now, we also have a few challenges along the way. A part of it is a lack of space. Now, it's important to note that most of the existing hospitals that we have were not actually constructed with research in mind. And so they were mainly constructed to render services, especially just cancer services. Now, and so because of that, we have constraints of space. For the clinical staff, it's a bit better, but the supporting staff is a bit difficult. And so we keep on positioning things in different areas of the hospital, making navigation a little bit more tedious. So in this case now, we're thinking that had it been, we had maybe a purposely built cancer centers where most of the things can be placed in one location, it would be very, very helpful. Now, when we started, we didn't have so much experience, and so most of the study documents, we didn't have it at all. And so especially the logs, delegation logs, data safety and monitoring meeting logs, and all those things. So we had to rely mostly from facilities from the University of Chicago Hospital. And so that was very, very helpful. In fact, we had to translate most of their documents to our own so that we can be able to use them and do the work completely. And of course, staff motivation was initially high, but along the line it became low because when there's so much hard work involved in clinical trials, and since it's an investigator-initiated study, there was not so much money to be able to compensate the staff adequately. But we just tell them that, well, if we can succeed, then the future is bright. And so to this, we feel that more, especially biotech or pharma involved clinical trials will be really much more better so that we can be able to support the staff a little bit more adequately. Now, we also observe that, most of the patients that we have are locally advanced. And of course, they are also treatment naive as well. Now, this is because of the widespread information that we have that most of our patients present at late stages. Now, some even come at stage 4, which we cannot actually continue to enroll them in the study. And so, but then that stage has to be taken into consideration. This is important, the fact that when in future clinical trials, if we want to enroll patients that are that have very early diseases, it may be a little bit difficult to accrue them in as fast as it should be. Now, rapid accrual is also there because, of course, there are no clinical trials to compete with the existing studies. So we didn't have problems in having patients for the trial. Another very important point is that our patients need more financial support. It's much more than in maybe developed countries where so many things like transportation and maybe basic drugs could be available for the patients. Most of our patients would like to come to the hospital, but they need more financial support. I can remember for some instance, we had to pay for accommodation for some patients who were coming to the clinic because they were not able to go back on time. We had to take care of them. Now, other instances, we had to buy simple handsets for about 3 patients who lost their handsets so that the study staff will be able to communicate with them very conveniently. Now, some of these requirements may not be there when you are doing studies in developed countries, but for us to be able to have good follow-up and then good clinical attendance, we need to go more extra to support some of our patients. Not all of them, just a few of them that may need such support. So such should be taken into consideration when we are planning our studies. So in conclusion, more cancer clinical trials can be conducted in sub-Saharan Africa if we have the infrastructure is a little bit more developed and then more trainings are conducted. Now, focused collaborations are needed. For instance, we had to work closely with the University of Chicago in terms of upgrading our facilities, training and supervision. So in such a way that we could also find a way of linking some of our sub-Saharan African countries with relevant high-income countries, be it Portuguese-speaking, French-speaking, and Spanish-speaking, so that they'll be able to flow well and be able to exchange information very seamlessly. Now, of course, we still need to understand the characteristics of our patients as well and what it means to do clinical trials in the sub-region so as to be able to succeed. And we still need more trials like this to be able to expose our investigators and our study teams to be able to undergo the clinical trial processes. Now, it is our hope that we want to expand this, our studies to other parts of the country and even the sub-region. And so this will still call for more support because, well, we know that there are no indigenous pharmaceutical companies in African countries, so we still need the support of the international community to support us in order to achieve this. We also intend to be able to train more investigators and team members so that all aspects of clinical trials can be safely conducted in the sub-region. Now, we've had so many collaborators that help us in this project. NIH supported myself with a Care for the Trial award, through which I was able to take some trainings in clinical trials. The University of Chicago has been very helpful in sponsoring this trial and then supervising the trial. Roche supported us with some of the materials and the trainings that we need for the clinical trial, so they have been very helpful, as well as Novartis that also provide opportunity for training, and the Breast Cancer Foundation that supported us in improving some of the infrastructures. So I thank you very much for your attention. Well done.
Thank you. Thank you so much, Dr. Tekim. This was very stimulating, and there is a lot of questions coming up. Let's go on with the next presenter, so that will wrap up all the questions towards the end. My pleasure having Dr. Banda from Malawi to present. No, from actually, I saw the presentation was from Zim, but he's from Malawi, but he's going to present his study, which is also a clinical trial design study. So we will be having him for the next, we've got, time, a little bit of time remaining, but we can get some, 5 to 10 minutes as well, presentation. Welcome, Dr. Banda.
Thank you so much, Doc. I'm sorry that at the moment you may not be able to see my face. I'm having challenges with my my laptop's camera. I'll try to log in with using my phone during the QA time. So I'll present on a study we did in Zimbabwe comparing 6 MV and 10 MV photon energies when treating cervical cancer. And my name is Chimamwe Banda, currently at the Malawi National Cancer Center, but the study was done in Zimbabwe at the Palinyatwa Group of Hospitals Radiotherapy Center. So as we may all be aware that radiotherapy efficacy is usually dependent on a lot of factors, but the two that come out strong are the ability of the treatment machine to deliver optimal dose to the target volume. At the same time, the treatment planner and the machine should be able to spare normal tissue. So the photon energy is the main factor that is the penetrating power of the machine to the target volume. And different techniques are used to deliver this dose. And one of the techniques is 3D CRT. And when it comes to 3D CRT, it is recommended that higher photon energies, which are greater than 10 megavoltage, are used when we're treating deep tumors. And this is just a pictorial view of what I just said, that the quality of the beam will it's going to depend on the energy. So the higher energies are going to penetrate deeper and deliver a higher dose to deep down the tissue. When we're comparing 6 and 10 MV, we can see from the right side of the screen that the percentage depth dose that is delivered by a 10 MV machine is a bit higher at 10 centimeters as compared to the 6 MV machine. So rationale to this study, at some point we were developing our cervical cancer protocols at the University of Zimbabwe, Palinyatwa, and there were some arguments that probably the 6 MV machine is not capable to deliver enough dose to treat cervical cancer. But as we see, in our setup, and maybe in most low resource settings, it is very difficult to find high energy machines, which may be expensive to buy and also maybe to run. And at the time of the study in Zimbabwe, we only had one machine which had a 10 MV energy, and the same machine had also other attributes which are better placed to be used for other cancers. And there isn't also much data comparing 10 MV and 6 MV treatment using 3D-CRT. And if you look at Zimbabwe, the most common cancers are gynecological cancers, mainly cervical cancer, and also in other sub-Saharan African settings, it's the same scenario. So if we put all our cervical cancer patients on the TNMV machine, that means it will be too much. And just a pictorial view, at that time, as I said earlier on, the machine, the DMX machine is the one that had a 10V, 10 MV14 and other attributes like electrons, and also 120 leaves of MLCs as compared to the other machines. So this machine was actually used for other cancers as in relation to cervical cancer. So we decided to compare the outcome and also the dosimetry when we use the 10 MV and 6 MV photon energies. And specifically, we wanted to check the dose to the target volume. In this case, the planning target volume, the maximum dose to the planning target volume, the minimum dose to the planning target volume, and also the average dose to the planning target volume. Also, we wanted to check the maximum dose to the organs at risk when treating cervical cancer. In this case, the bladder, the rectum, the intestines, and also the femoral heads. And also we went further to also check the outcomes of the patient at 3 months. In this case, we were looking at the response to the treatment, like complete response and maybe non-response to the treatment. So we did a retrospective analysis of our medical records, looking at the time. This study was a dissertation, so we had retrospectively looked at our records for about 2 years, and the treatment plans were stratified into 2 arms, the 10 MV arm and the 6 MV arm, and respectively we analyzed and checked the differences between the two treatment arms. So during that study period, we saw around 875 cervical cancer patients, and 82 met the inclusion criteria, and there was a bigger chunk in the 6 MV as compared to the 10 MV. And at 3 months post-treatment, we found out that the response in the 10 MV group was 95% with complete response, as compared to 91% in the 6 MV with complete response. And the differences between the studied parameters, like I said earlier on, we looked at the minimum dose to planning target volume, maximum dose to planning target volume, the average dose. We also looked at conformity index and homogeneity index. On those parameters, on dose to the target volume, we can see that only 2 were statistically significantly different: the minimum dose to planning target volume and the homogeneity index. All the other parameters were not statistically different between the 2 groups. All the maximum doses to the organs at risk were also not statistically different between the two groups. So we looking at the results, only 2 parameters out of the 9 that we studied where we were favoring the 10 MV photon energy. And if we look at the physics of photon radiation, we see that when we're using 3D CRT, usually the 10 MV is a bit superior to the 6 MV. But if we look at the other parameters, they were also not very different. So the 10 MV and the 6 MV, they're of course low energy and high energy, but they're close to one another, and you can see that it's possible that they can practically they're capable of achieving similar outcomes. And so we, from this retrospective study, we concluded that 10 MV and 6 MV, the outcomes are comparable, and that the 6 MV can also be successfully used to treat deep tumors where the 10 MV is not available. And we are not saying that 10 MV is still superior because of the dose homogeneity and all other parameters that are superior. But for us to get a proper study, proper follow-up study, like prospective studies, may be needed to at least be so confident to tell this conclusion. And looking at the study that we did, it was a retrospective study, but it is the real life situation that we face in our hospitals as compared to the clinical trials. So I acknowledge the input from my supervisors at Palinyata Radiotherapy Center, Drs. Ntokozondrovu and Dr. Nyamunga, and also the Mr. Bingara, the statistician, who helped a lot, and all staff at Palinyata Radiotherapy Center who helped a lot in all aspects during my data collection and all aspects of the study. Thank you so much.
Thank you, Dr. Banda. Thank you mostly for keeping time as well. For both of you and Dr. Ntekim, we have mostly congratulatory messages, but we also have about 7 questions or 8 questions overall. I'll start with Dr. Ntekim. We have questions lined up from Dr. Mutebi, Dr. Fidel, Dr. Penshab, Mushonga, Abid Altman, and Christopher Williams. So Fidel asks regarding to Dr. Ntekim, so how is the current status of accessibility and affordability of trastuzumab? Assuming that this study is positive, will patients be able to afford trastuzumab? Quickly, if you can respond to the question.
Yes, thank you very much. In Nigeria, where there was the affordability was a little bit effective. But of recent, Roche and the government has come up with some programs that have made the price of accepting much more cheaper than what it was before. There's a program that the patient will pay like maybe just like 30% of the cost, then the government will pay, and then Roche will also support. It's another program that the government will support greater part for more indigent patients. But by and large, it's not covering the entire population. So everything is still being expected to improve. So the situation is improving more than what it was before. So that's what I can say.
Thank you. I'll try to link up questions. For example, Dr. Mutebi asked if there is any form of adverse effects, and that is in relation with the question from Dr. Christopher Williams regarding any cardiac, and how were you able to monitor for cardiac complications. So the other question from Dr. Christopher Williams was, in the event of the success of the study, how are you going to make sure that the medications are going to be available in the future? I think this, you've responded to it already.
Okay, in terms of toxicity.
Adverse effects.
Okay, adverse effects. Well, as part of during the study, we had some few patients that had maybe like a grade 3 diarrhea. That was one of the patients that we had a serious adverse effect, but it was just grade 3. They were admitted and then they all recovered. Some of them really had severe diarrhea that was blood-stained, but they were all okay. Now, the other ones were neutropenia in some of them, but they usually recover very well with the pifigastrin. Now, apart from that, there were no other serious adverse events. Now, in terms of cardiac toxicity, for those who are progressing to FEC, we have a very strict monitoring guideline for the cardiac status, because we do echo for them every 6 weeks while they are on study. And then once we see that the left ventricular ejection fraction is reduced by 15, then we have to stop till it recovers. And so we have a very strict protocol for monitoring the cardiac events. And we have a cardiologist in our team who is interested in oncology, cardiology. And so all our patients, so far we haven't had any event that we had to stop accepting because of cardiac events.
Thank you.
In terms of maybe making the government to do it, well, we just want to have the results, and then when we come out with the final outcome of the result, we have to present it and then circulate it widely. We may not be able to do it alone. We may have to contact some other advocacy groups, like survivors groups and other cancer agencies, NGOs, to be able to press upon the government. And those who can also have access to the policymakers, we just want to present these results so that we'll be able to take off from there. Thank you.
Thank you. So one last question, I'm trying to wrap up about 2 questions, is mainly about the pharma involvement. One question from Matthew Penchab regards the positives. What do you think would be the positives of involvement of pharma, and does it outweigh the negatives? And that is a bit related to the question from Dr. Fidel as well. Another question that you could respond to as well is whether a 95% visit by the patient would be reproducible outside of a clinical trial, and that is from Dr. Abid Atman in Kenya.
Well, let's start with the 95% clinical attendance. Well, that is just to show that a lot of our patients can always visit clinics if they are supported, and especially in terms of their own economic ability. A lot of them may have some economic issues that may not be able to visit the clinic, but this study was supporting them very closely and then monitoring them very closely with the use of those people that were actually navigating them. So we don't really know, because sometimes it is mostly economic issues. That is what we could identify from the study, that the patients are economically all right, they should be able to visit the clinic as and when due, because some of them travel long distances to get to clinics, and then there could be some other family issues that may have some economic pressures on them. Now, in relation to the pharma, I think it's a win-win situation, because the pharma will gain and the population will gain. Now, the pharma will gain, I can say that, well, mostly as most of these drugs are not expensive, a lot of them may not be getting a market in the country, but if it is popularized and then there could be some support for the achievements, then it could be so. And then in terms of other research that could also help humanity, because like, as we have some resistant cases, we are also going to do some genomic studies to understand some other targets that may overcome the resistance. And this could also be beneficial to the pharma and other researchers, through which they should be able to formulate other things that can also help even Africans and those in the diaspora, because we still have a lot of Africans in there. And then a unique genetic composition of Africans will also be able to be identified in this study. So I've forgotten any other one.
No, I guess the next questions are for Dr. Banda. Thank you so much, Dr. Tekim.
Yeah,
Banda, you have 3 minutes with me. The first question regards, thank you again. You have many congratulatory messages, but the first question regards the outcomes, whether, I think you've talked about it, maybe you can stress it a bit more, whether the outcomes were similar regarding, between the two arms, and also the way you've done your sample size and how you've randomized. Was it a 3:1 type of randomization, and how did you do it? How was the sample? I understand it was retrospective, but how did you do 6 versus 10, and who was there in terms of numbers? Maybe we can start with those. You're muted. You're muted. Okay.
Oh, sorry about that. So
yeah,
sorry about that. So on the sample size, it was actually a 1-to-1, and we were supposed to have around 61, at least 61 patients in each group. But because of the challenges with documentation, the only number of patients that we could get in the 10MV group was around 20. So we had initially challenges, but with the statistician, after we tried to calculate the power that could be changed if we took less patients in the 10MV group, and it showed that it didn't make any difference when we take 20 patients in the other group. So we had some power calculations, and the power did not change that much. Change from 80%, the initial planned power, to 79%.
Thank you. I intend to give the word to Melinda in about a minute, but maybe you can go on and speak about how similar the two groups were, and potentially if you looked at the toxicity depending on the stages, or any outcome depending on the stages.
So the sample was local advanced cervical cancer, like stage 1, stage 2 to 4A mainly. So those cancers that are not amenable to surgery, but can be cured with radiotherapy. So the toxicities, on the issue of toxicities, because the treatment for local advanced cervical cancer is both chemo and radiotherapy. So it was very difficult to streamline from where the toxicities were coming from, because the toxicities are mainly similar. And from our initial plan, we did not plan to actually to look at the actual toxicity, because they usually they are also the same when it comes to chemotherapy and radiotherapy. So most of the patients also got chemotherapy. So it was difficult to analyze on the actual toxicities. And the other part again, can you remind me? I can't get the.
The question was regarding if you've done any correlation between stages in terms of outcomes or toxicity.
Mm-hmm. Maybe I don't get the question properly. Can you explain?
Okay, so we're chewing minutes, but so the question is regarding if you've done stratification according to stages and looked at the outcomes and toxicity, maybe in a few seconds.
No, at that time it was very difficult to substratify because of the sample as well, man. It was one of the limitations that we couldn't substratify to a certain level. Mm-hmm. Yeah, so because of the limitation in the sample size, mm-hmm. We couldn't analyze some of the nitty-gritty factors because of that limitation.
All right. Thank you so much, Dr. Banda. This was very stimulating. I believe there will be more questions. I have done, we've gone overboard for 12 minutes, but Dr. Melinda, you're on as the next moderator of the next part. Thank you.
Hi, everyone. Thank you, Achille, for holding this quite well and keeping on time. So we will just move on to the next segments, which will be, the first one will be on COVID-19 and pediatric cancers. And we have two abstracts. The first one was presented by Dr. Randall from Botswana and the team. And this looked at, they did evaluate patterns of cervical cancer diagnosis and treatment initiation before and during COVID, knowing the impact COVID-19 has had on all of us. So soon after that one, we get straight into Dr. Mwenda's abstract, which looked at barriers to effective childhood cancer control in Kenya. Thank you. So Dr. Randall, you can take over.
Sure. Hello, everyone. Clearly, I am not an African researcher. I'll just call that out. I'm lucky enough to collaborate with an embedded team in Botswana. Unfortunately, most of them couldn't be here today because it's a public holiday. So I am presenting on behalf of the team. But my co-lead, Dr. Serby Grover, is on, who is a radiation oncologist in Botswana. So let me share my screen. All right. All look good? Okay. So I'm a behavioral and implementation scientist, and much of my work has been in the United States in cervical cancer. But in the last 5 years, I've turned my focus towards thinking about inequities at the global level. And clearly, when you think about cervical cancer, there's a substantial a disparity. I'm sorry, this is going to do a timing. Just one sec, not time. All right, so as I noted, these are my colleagues, again, that are very much the central focus and drive of this research program, many of which have worked in this space for decades. And I'm just presenting on some of the work that we're doing. So this won't come to surprise. This is sort of oriented towards those in the United States who think about why, we really should think at disparities, particularly in cervical cancer at the global level. Where there's about 4,000 deaths in cervical cancer in the United States, there's of course over 300,000 globally, and the vast majority of these are in low and middle income countries such as Botswana. Botswana has a very high rate of high prevalence of both HIV and cervical cancer. And when you look at that mortality rate, 20.1 per 100,000 versus the United States, that's a very clear case for why there needs to be dedicated focus on improving care and outcomes. So there is a national cervical cancer prevention program. However, despite this national program, the majority of patients do present with locally advanced disease for cervical cancer in Botswana. And for these patients, the recommended evidence-based care for most of them are chemoradiation therapy. Luckily in 2015, in part with my colleague, Dr. Grover, a gynecological multidisciplinary team clinic was set up at the National Referral Center. And that is much of where this research is done, in addition to a longitudinal cohort, which is the data is presenting on. So while patients, of course, live across the country, the care is centralized in the capital. And this is at Princess Marina Hospital, in addition to Gaborone Private Hospital. And this is where the vast majority of patients diagnosed with cervical cancer are treated in country. So some of our work prior was looking at sort of delays at different points after patients do reach. Of course, there's some patients that are lost before they even get to treatment. But what we found was sort of that the biggest delays were from that diagnosis to actually getting to the clinic. And then within clinic, there's been different strategies that have been implemented to try to make sure that patients not only receive care in a timely manner, but then of course, complete their care. And so some of our prior qualitative work, we looked at sort of different determinants that might be driving this, and not surprising. Some of this is of course driven by the distance in which some patients have to travel to get care, but also sort of a delays in referrals. We won't be talking about that today, but we're sort of transitioning to some implementation trials that are hopefully going to improve this by using centralized outreach. So our ASCO poster was really specifically looking again at this sort of longitudinal cohort from 2015 to 2020 in patterns of cervical cancer diagnosis and treatment initiation. So this is that sort of first start of treatment. And we looked at timeliness of treatment defined by the number of days between their first clinical visit and initiation of first-line treatment. And we dichotomized that based on 30 days. Our primary exposure was the time period, so before the pandemic and of course during the pandemic, defined by month of first visit. And then we use multivariable, we use summary statistics in addition to multivariable logit, adjusting for key covariates. So what we found in sort of our initial presentation at ASCO was that there was 1,500 patients, a little over 1,500 patients who seen at this clinic, these are all gynecological cancers, that the proportion of patients with cervical cancer decreased from after or during the pandemic. So before the pandemic, it was about 80% of all patients with gynecological cancer and dropped down to about 68%. Of those that were treated for cervical cancer, the vast majority, of course, in this time period were pre-pandemic. But when you compared the two, those during the pandemic were much less likely to have attended a screening clinic prior to treatment, and significantly more likely to experience treatment delays. And this association with treatment delays during the pandemic, not surprisingly, even when you adjusted for key covariates, was a 7-fold higher likelihood of treatment delays in those patients diagnosed during the pandemic in comparison to before. So right now we're working a little bit more with the data, and we just want to sort of give a glimpse of what we'll be working on. When we looked at our initial data, we thought we should maybe restrict it to, this is different than how we presented it at ASCO, restricted to the time frames, and so they were aligned in calendar time. So April 2018 to, sorry, I'm trying to see my calendar, my screen a little bit more. Here you go. April 2018 through December 2019, and then match that to the post or during pandemic period. And we also realized that sort of just having a dichotomous delay or no delay, we're missing those patients that actually had no treatment before and after. And so you'll see here that similar to what we presented at ASCO, a great reduction in, so that blue bar from 88% to 11% of all the patients in these two periods that had no delay. And then, sorry, these are in comparison to the two, but then those with no treatment also increased. Delay were slightly higher as well, but actually you'll see that those tail ends are where we're seeing it. And then sort of the overall takeaway, you know, that we're also seeing no significant differences in the proportion of late stage cancers before and during the pandemic. However, we are seeing a lower proportion of cervical cancer overall, so as I noted before. And so what we're sort of anticipating is that there will be some maybe increases in late stage cervical cancer down the road, and possibly due to missed screening. And with that, I will stop. Dr. Grover, anything to add?
No, this was great. Like Kate said, you know, it's too bad. It's a public holiday, and a lot of our collaborators who have been working on this, and a lot of the junior folks who've been involved with the project couldn't make it because a lot of folks are traveling. So please let us know if you have any questions, and we'll do our best to answer.
Thank you so much, Dr. Rendell, for sharing the experience from Botswana, which I think most probably simulates most cancer centers, regardless of, you know, location, really. Anyone with any follow-up questions that they may have, so that Dr. Rendell may maybe elaborate more on some aspects? I'll check the chat as well. And I don't see any pressing questions. So maybe people are still digesting. We'll move on to the next presentation from Dr. Mwenda from Kenya, who looked at barriers to effective childhood cancer control in pediatric patients. Dr. Mwenda.
Thank you very much, and good evening, good morning. Confirm if my slides are visible.
Yes, I can see your slides.
Thank you. So I'll be making my presentation on barriers to effective childhood cancer control in Kenya. And I think as part of background, we do, I think all of us do know that childhood cancers approximately 80% occur in low and middle income countries. A fact that is different from adult cancers, childhood cancers, management of childhood cancer is quite cost effective in our economic settings. And overall, we do get better outcomes for management of childhood cancers. But we do note that there's a clear survival disparities if we compare low and middle income countries and high income countries, with survival in low and middle income countries being between 10 to 30%, as compared to very high survival rates of 80 to 90% in high income countries. And to just situate childhood cancer control within the local context in Kenya, Kenya is currently implementing a decentralization of cancer care from a very centralized system of a few referral centers at the at major cities, especially the capital city, to setting up of regional cancer centers. And this has been taking place especially from the year 2019 onwards. But despite investment in cancer control in the country, especially for the last 5 years, childhood cancer control is still characterized by late referrals and poor outcomes. So we sought out then to try to identify individual health system and policy barriers to effective childhood cancer control in Kenya. We adopted a mixed methods approach. So quantitatively, we looked at the retrospective records of childhood cancer cases at the main referral center. That's the National Cancer Referral Hospital, Kenyatta National Hospital in the capital city. And we looked at the 6-year record review, and also we did capacity assessments of the regional centers, so the newly established regional centers, on the capability of diagnosing and managing childhood cancers. And then we qualitatively, we conducted focus group discussions and key informant interviews targeting caregivers of children with cancer admitted at the National Referral Hospital, and then the key informant interviews targeting policymakers and childhood cancer specialists in both diagnosis and management. So these are our key findings. First, care seeking and health system delays do contribute to poor outcomes. We noted that, especially the first delay between the first reported occurrence of symptoms to when the diagnosis was confirmed, a mean of 26 days, but more importantly, a huge range, from 0 days to slightly below 3,600 days, and 52% of all the cases having more than or equal to 60 days between the time the symptoms occurred and the time the diagnosis was confirmed. And then between diagnosis to treatment, again, on the average 11 days, but again, a huge difference up to, as little over 1,000 days, and again, 51% more than 60 days, which is set as a standard. And secondly, we did find that health system disruptions also impact care. And we did note that some industrial action among healthcare workers impacted referrals to the National Referral Center, especially between 2013 and 2017. Third, we noted that lengthy hospital stays is a major burden for caregivers, and the two major reasons for this is a poorly structured care process, and especially inadequate financing from the National Hospital, now Health Insurance Fund, which caused treatment interruptions. And because the existing cover was, just covers the same as adults, sometimes up to 6 treatment cycles, but noting that some childhood cancers require up to 24 cycles of treatment. So as soon as the cover is exhausted, treatment is disrupted, and these children, together with their caregivers, tend to stay within the hospitals because they can be discharged with the treatment being complete. And then the regional cancer centers, we noted that they have a minimum infrastructure for early diagnosis and management of childhood cancers. However, the key gap is in specialized personnel in both diagnosis and management. And then next, at policy level, we did note that there's a poor implementation of policies in control of childhood cancers, but we did note that the opportunities that exist for successful implementation of the global initiative for childhood cancers. As you are aware, childhood cancers is one of the 3 cancers that have global initiatives, the others being cervical cancer, breast cancer. So to just give some more detail, we do note here that, looking at the epidemiology, the different types of cancers referred to the National Referral Center, are comparable to both, the model data from GlobalCan for the country and also, data that we have from a network of hospital-based registries on childhood cancer. It also, the burden also, mirrors the 6 focus cancers for the Global Childhood Cancer Initiative by WHO that focuses on, acute lymphoblastic leukemia, Baxter lymphoma, Hodgkin's lymphoma, retinoblastoma, nephroblastoma, and low-grade glioma. So, implementing this initiative then can be able to reduce the burden of childhood cancers in the country. As mentioned, the impact of health system disruptions, when we plotted the burden across years of childhood cancer referrals to the National Referral Center, we did note this dip. And initially we were not able to explain this, but when we went back to the records, we were able to note that that's a period that in country we had a series of both regional and national healthcare worker strikes. From the year 2013 to 2017. And as you can see, as much as the National Referral Center itself was not affected by these strikes, we can see that there's a major impacts because majority of the cases are referred from the, the county hospitals, the subnational hospitals. On examining barriers and opportunities, we did note that at the community level, a key barriers noted as low awareness, but again, with the ongoing emphasis on community strategy in the country, that was noted as an opportunity for increasing awareness on childhood cancers. In the healthcare system level, I know low index of suspicion, especially at primary care, these were the referrals emanate from. And an opportunity there is to integrate and of course increase capacity for primary healthcare workers to be able to suspect and refer childhood cancers early. And then at policy level, financing and varying treatment protocols were noted as key barriers. But again, ongoing, focus on universal health coverage and also decentralization of care was noted as main opportunities. We did examine also, the situation of the country, especially in implementing the Global Initiative for Childhood Cancer Control that, as you know, as a series of components, with mnemonic cure all, the first being centers of excellence. And again, here with the establishment of the regional comprehensive cancer centers, that was noted as a key opportunity to, have centers of excellence in offering childhood cancer care. And then on universal health coverage, Kenya has been, having discussions around UHCA since the year 2018. And again, this was noted as a, a critical opportunity for implementing this initiative. On harmonization of regimens, this was noted as a key issue, that we have various treatment regimens. But again, harmonization of regimens was noted to be a critical intervention that can improve care. On evaluation and monitoring, including data and information systems, adoption of electronic medical record system that can also track cure rates, and again, continuous training and mentorship, and of course, very, very necessary high quality population-based cancer registries and robust surveillance system that can be able to assist in evaluating treatment outcomes. In advocacy, it was noted that, advocacy has to take place at all levels, community health system and also at policy level. And again, there's need for coordination to minimize duplication of efforts, especially in the context that there are so many actors, that drive advocacy for not just childhood cancer control, but overall cancer control in Kenya. On financing, it was noted that there's need for the national hospital, not hospital now, it's actually National Health Insurance Fund to restructure the childhood cancer package, and also working on more private public sector partnerships, access programs, and integrating within existing financing mechanisms to drive childhood cancer control in Kenya. And then on policies, there's noted that there's a need for clear monitoring and evaluation of implementation, strengthening governance structure at county levels. And one key issue that was noted is to ensure development of cancer control action plans at county level, since Kenya has a decentralized system of healthcare provision. And although policies are made at the national level, then there's need for action plans being developed at the county level where services are provided. We are happy to note that even before these findings were published, some public health action emanated from it. So the findings were disseminated to the National Technical Working Group on Childhood Cancer Control in Kenya. And this TWG developed an advisory for differentiated insurance cover for childhood cancers that was shared with the National Health Insurance Fund. And this advisory is actually informing the currently ongoing restructuring of that cover so that it can be able to cover the entire aspect of not just treatment, but also diagnosis of childhood cancer. We plan as part of future directions on this research to conduct implementation research on various models of care, and also having an investment case for implementing the World Health Organization Childhood Cancer Control Initiative. I wish to appreciate these three institutions: Conquer Cancer, ASCO Foundation, the National Cancer Control Program, Ministry of Health, and also the National Cancer Institute of Kenya. Thank you very much.
Thank you so much, Dr. Mwenda, for this insightful presentation, especially noting how much underrepresentation there is regarding, childhood cancers. Any pressing questions that we have from the audience before I read the questions that we may have on the chart? So one question I have, which came from Fidel, is, Fidel, can you go ahead and answer the question?
Yeah, so my question was, the delays that Dr. Mwenda presented mostly, I think they packed all the childhood cancers, but I know that symptoms differ when you consider Wilms tumor, ALL, lymphomas. So would they like to know if they were able to unpack these delays considering the diagnosis?
Yeah, so maybe I can take that. Yes, so that's part of an ongoing further analysis of the data that we're undertaking to be able to understand. First of all, we wanted to actually look at 3 delays, but one of the delays is very difficult to be able to look at it from retrospective information because of the quality of data. But yes, we're trying to compare the delays between the various cancers, but not just the various cancers, but also other socioeconomic strata of the various cases referred to the national hospital. So where they come from, the socioeconomic status of the caregivers. So yes, that's actually further analysis that you're conducting at the moment. Hope we're able to share the findings. Thank you.
Thanks, Dr. Mwenda. I also have another question from Atundo Murunda. He says, do the education levels of parents or even, caregivers have any significance in influencing the health-seeking behavior?
Yes, thank you for that question. Yes, and again, I think it's related to the previous question. Yes, we're exploring further to see if some of these other socioeconomic factors are there. What we do know is the economic factor is very, very critical in seeking care, especially because the existing cover by the National Health Insurance Fund didn't cover diagnostics. So even if these children are referred early, but the investigations are requested, but they're not done because the families cannot raise the funds, then these children are not able to access care quickly. And so actually that's one of the focus of the restructuring of the National Health Insurance Fund, so that they don't just cover the entire area of treatment, but also diagnostics. So yes, and I think as we do the further analysis, we should be able to identify even more critical factors for care seeking for childhood cancers. Thank you.
All right. Yeah, and one important comment, which I also see in the chart, is that, this cure-all model can actually be adopted, in adult cancers as well. But just maybe as a follow-up, are there any research models that have, that are in process or you have come up with based on the findings from what you just did?
Come again?
Yeah.
Any research models that have developed based on the findings that you just presented?
Hoping that I'm getting your question correct. What is coming out from our work is that we're planning to do an investment case. Now, that's not isolated for childhood cancers. It's an effort ongoing for cancer control in the country, just because for us to be able to advocate for financing, there's been a request from the the financing side that we have to make a case on return on investment in cancer control. We've done that for cervical and breast cancers. So looking at the at our findings, the plan now is to be able to do an investment case for childhood cancer control. so that we have specifics. And even before we do that work, we already know that, childhood cancer management has the best return on investment. Why? Because you have better outcomes, the treatment is cost effective. These children, if they're cured, they're able to live, a long, productive lives. So to us, that's the next focus, having a comprehensive investment case for childhood cancer control in Kenya. Thank you.
Thank you. Any questions that any of our audience may have directed to Dr. Mwenda? Okay, I don't see anybody raising their hand. And
ask that question about the investment. And is it the same framework that was used by the Lancet Commission? I think I put it in the chat. So thank you for answering my question before. It's about how the Lancet Commission on Childhood Cancer presented new evidence to justify the investment and the framework. So is it the similar framework?
Correct. Yes, it's a similar framework. It's just localizing it now for the country. We will be doing it most likely with the World Health Organization adopting the WHO approaches, but it's basically exactly the same work.
Thank you, Dr. Mwenda. Maybe just one follow-up question to Dr. Rental. Like based on your findings from when you looked at patterns of care, diagnosis and treatment, pre and post-COVID, how do you see those findings impact policy in sub-Saharan Africa in general? Just maybe in a minute or so before we move on to the next presenters, just to keep on time.
Sure, and much of what Dr. Mendes said resonates in Botswana as well with regard to rural, with regard to education. We also looked at it with HIV, thinking that those who are in HIV care might be less likely to have delays. We haven't actually seen that. But I think that what we've directly taken these results overall, both the pandemic and then also before, is that you sort of have to work within the context of the system. And so what we are currently working on, hoping to get funded in the next couple of months, is actually a study where we will be implementing with policy, with the Ministry of Health, with different community partners working through the national lab to try to decrease delays from the start. So the vast majority, there's two sort of labs, pathology labs, thinking about patient outreach directly from there, so we can sort of get around some of these delays that happen from the communication. And then a second level by which we'll be having direct patient support once they get to the clinic. So fingers crossed, and that's with the colleagues at the University of Botswana, that will be funded. If not, we'll find another way to keep moving forward.
Thank you. Thank you. So we can move on to the last segment, which is Value in Cancer Care, where we have 3 abstracts, which will be presented by Dr. Hamid Omar, Voice of ASCO, then the next one by Dr. Fidel, and the last one by Dr. Tulani. So Dr. Omar, may you take the floor and go ahead with the presentation.
Okay, let me just share my screen quickly. What's going on here?
I'm happy to share your screen, Dr. Ham.
Yeah, I don't know what's happening here. Just can you see it now?
It's coming up.
It's coming up, but
yeah.
What about now?
No, unfortunately not.
Let me, if you allow me, I'll share your screen.
Let me stop sharing then, okay? Then I can try again. What about now?
Perfect.
Okay. Yeah.
Okay, you can see it now, yeah?
Yeah. We have it on. You can go ahead.
Great, thank you. I think mine is more of taking a break from all the sciences and all the good stuff. ASCO Voices was a special session It was not a scientific session. It was more of a personal, compelling stories. And this was what it was all about. There were 5 talks which were selected, and I was lucky to be one of them at ASCO. And it was supposed to be just a simple personal story that talks about interest in oncology, real experience specifically from in this part of the world. But mine was more along the lines of still the problems that we see as an oncologist in Kenya. And I tried to summarize in 7 minutes in that narration by talking about the current state of cancer care in Kenya, resources, which are the cancer resources in Kenya, the workforce and the personnel in terms of how many oncologists we have, the cost of cancer care, which is a really a topic that cannot be exhausted today, and the treatment challenges. So the global theme that I started off in my talk was for 2022 is closing the cancer care gap. And there are a lot of huge gaps in Kenya right now. Building on the data that was presented by Dr. Mwenda, who was ahead of me, you could see the picture of Kenya's cancer care, state of cancer care. And there's a lot of issues. So in terms of the cancer care gaps. Quick one in terms of epidemiology of cancer. This was 2018 data. If you see on the upper left, it talks about the population of Africa. That's 1 billion in 2019. Out of that, 811,000 cases were diagnosed in 2019. Out of that, 5,500, 500,000 died. You can imagine how near those numbers are. And on the right side, you could see the breast cancer burden was the highest, followed by cervix, prostate, colorectal, and all the way down. And you could see the mortality on the corresponding pattern. On the same year, 2019, Kenyan population stood at 52 million, and we had an annual incidence rate of 47,000. Out of that, 32 mortality cases. That's a lot of death, and we really need to close that gap. Similarly, on the right side, you could see in 2019, breast was the leading one. You can see the mortality is almost 7%, and the incidence at 12%, which is really, really close. You literally diagnosing almost the same type of people, same number of people that are dying. And then in terms of health systems in 2019 or 2020, from the data from the cancer country profiles, you could see I'll look at this data later on in the following slides. But in 2019, if you look at the quality of mortality registration, there was no coverage. So as much as we're really trying to harmonize our data, we still have a long way to go, even though this was 2019, things are a little better now. In terms of resource, you could see the external beam radiotherapy in 2019, they were only at an average of 2.3. Mammography 15, CT scanning 34 in the country of 54 million people. Really, this is just to underscore the gaps in terms of health system capacity. And then I'll move to in terms of human resource in 2022. Right now, I did a cursory search in the Kenya medical database of looking at the number of oncologists, and believe you or not, 54 million Kenyans right now, we have less than 100 oncologists. To be precise, actually, we have around 52. The number of radiotherapy machines in Kenya as well, in 2022, this is where we are, a total of 14 Linacs and 2 Cobalt. Cobalt is the older generation of radiotherapy machines. And all these are the cancer centers in Kenya, Nakuru, Mombasa, Garissa. It's good to see a couple of names outside the city of Nairobi, because the whole idea of decentralizing cancer care is really what will close the gaps. Brachytherapy machines, as of 2022, we have 10 machines in the country. Majority of these are also in the capital city, but there are a couple of machines as well outside Nairobi, but not many. Radiation therapists, which are very invaluable people who work with us, and medical physicists. In Kenya, we have 30 of them. and the radiation therapies, they're on average of 60 to 80. And medical dosimetry is literally 1 in the whole country. Oncology nurses, I could not actually find unavailable data, but what I know is there are very few in the country. So the challenge is on the backdrop of what I've just mentioned, really cuts across cancer awareness, poor health-seeking behaviors of Kenyan population. Late presentation is very common. Financial toxicity and catastrophic spending associated with cancer, lack of cancer care equity. The death sentence is really a badge for the poor. Climate change continue to affect a lot of non-communicable diseases, but these are compounded more even by the stigma and the cultural lack of cultural nuances, which really leads to treatment, the lack of treatment compliance. We're really not doing a good job in terms of population-based studies. We do have registries, cancer registries, but still far off the mark, and a lot of other personalized and factors need also to be considered in terms of ethnicity. Different ethnic communities, we have specific diseases which are very common in particular type of tribes in Kenya: religion, gender, economic status, low uptake of health insurance. Only 20% of Kenyans are insured. Complex healthcare system, the healthcare is devolved to the counties, but really there's still no proper devolved cancer care. Coping mechanisms of cancer care in Kenya include, literally is a family.
We may be losing you, Dr. Omar. I think he's having problems with his network.
In Africa. Okay.
We may have lost you a bit, Dr. Omar.
Can you hear me now? Am I audible now?
Yes.
Am I back?
Yes, you're back. Thank you.
Good. Okay, good. Yes, so I was talking about the impact of financial toxicity, which usually range from, exorbitant cost in terms of care. These are the effect. This was a study I picked from the internet, and it might not reflect the real effect of Kenya, but I assume it's really a good to be extrapolated, and in terms of financial toxicity, compromises on other facets of spending required, and cancer taking a huge chunk of that funding. But with all that picture that I have painted, there is hope. Right now, the multiple comprehensive cancer centers that are coming up, the National Cancer Control Program at the Ministry of Health is really doing a good job, but we really need to pick the pace a little faster. Okay, among those are the three, Mombasa, and Garissa, and Nakuru are the new cancer centers which are already established. And Meru, Nyeri, Kisumu, these are another 3 cities which also have plans underway and in building their own a new cancer center. This is the Nakuru Cancer Center, which was just launched a month ago. Has got fully equipped Varian 3D system and brachytherapy, which is really great news for the local people. This is another one, Garissa Cancer Center in the rural part of northern Kenya, which is also equipped by Varian and has got 3D and even IMRT and services, as well as brachytherapy. That is President Kenyatta launching the Mombasa Cancer Center. Mombasa is the second largest city in Kenya, and which is really a good, great story for the people living in the coastal region of Mombasa city. So the feasible action plans already been said, but we just need to really work on robust community-based cancer centers, really, and work closing the gaps, specifically on more oncologists. You remember that ratio, which is very alarming. Nurses as well, oncology nurses are really off the mark. Financial toxicity is really a problem, catastrophic spending. So we really need to bring up that health insurance uptake number in Kenya, and and motivate our own cancer researchers so that we have data that can inform our policy decisions. Universal healthcare coverage is also something Kenya is mulling. It's been already tried in a couple of pilot projects in different counties in Kenya. Kenya's per capita expenditure on healthcare stands at that number compared to, say, Netherlands, which is a very first world country at 5,202. So you can imagine that gap is quite wide. Medical tourism in Kenya is quite common. A lot of people still go abroad for treatment, and the complications in terms of personal, individual family, and the government losing on the millions is really very clear. So I want to underscore that healthcare equity starts with quality of care. So healthcare disparity is very common in Kenya, and it's really bad to have a cancer overall, and it's even worse when you're very poor. Hence the statement I've mentioned to be a badge of death. The gap is really high, and the highly educated and the urban-rural migration is really substantial, and it's really contributing to the disparities in cancer care in Kenya. This was my paper talking about the in detail is what I've mentioned about Kenya, the need for closing the cancer care gap in Kenya. This is my favorite quote in cancer care world. Cancer does not have a face until it's yours or someone you know. But we cannot have all of us cancers just to know the importance of the less fortunate. So we really need to, as stakeholders and the opinion leaders, we really need to make sure that doesn't happen. Thank you.
Thank you so much, Dr. Omar, for the insightful presentation. I think we'll move on to Dr. Fidel's presentation next, just for the purpose of time. Dr. Fidel.
Yes, let me try to share my screen. Can you see my screen?
Yes, perfect, thanks.
Okay. So thank you so much for the opportunity to speak. Mine is, I was going to be like Omar and say it's away from the pure science of oncology, but also another part of science that we need to talk about, which is value-based cancer care. And for my abstract that I submitted to ASCO was looking at the initiative of Choosing Wisely. And some of you, as you probably are aware, Choosing Wisely is an initiative that has been all over the world now. We just probably started talking about it in Africa, but it's an initiative that was started in the US. And the main objective that this initiative is to advance a dialogue between all the stakeholders, patients, caregivers, other stakeholders like policymakers, on how to avoid unnecessary medical interventions, treatments, tests, and other procedures that we do in oncology. It's a wide initiative, but for the oncology part, which is mostly what I'm going to be talking about right now. So as I said, it started in high-income countries with Choosing Wisely US and then Canada. And then of recent, that was Choosing Wisely India. And then we came with Choosing Wisely Africa, which I'm also going to share about you. But mostly what this initiative does is to come up with a list of practices that people think are really not necessary for cancer care. And in doing so, we think we'll be able to achieve value-based cancer care. And some of the targets of Choosing Wisely initiative is, around research, screening, early detection, diagnosis, treatment, but also, as I said, in terms of a systematic approach, we also look at health policies like funding of healthcare, and also training the workforce and also retaining the workforce. How do we choose wisely in all those sectors? So 2020, we published the first list of Choosing Wisely Africa. A group of people came together and published this list of practices that we believe are not really necessary right now on the continent, given the low expenditures that we have in terms of the budget that is allocated for healthcare. How can we actually use the little funding that we have actually to maximize the benefit and the outcome for our patients? So some of these lists talk about, the need not to actually do some of tests to detect cancers if they are patients that are asymptomatic, the need for multidisciplinary cancer care, where you need inputs from other disciplines, and also the need for staging before you treat patients. So these are different practices that we published, and I welcome you to read this paper. So the study that we presented at ASCO was actually more of validating this list. So we came up with this list. A group of oncologists on the continent came up with the list, but we wanted to see how the frontline oncologists think about the list. So it was kind of validating this list. So the method was we shared electronic survey with questions to different oncologists on the continent. The survey was actually looking at the information capturing about awareness of the Choosing Wisely Africa initiative, which, as I said, we published, and whether they agreed with the recommendation that we gave, and also looking at whether they actually do concur with the practices. Like, for example, do we, if we are saying that patients should not get, patients with metastatic breast cancer should not get combination chemotherapy, but rather get a single agent, are they people, is this how they really practice in their usual practice? So the results were actually encouraging because of the 49 individuals that responded to the survey, more than half were females, which is also encouraging. And as you all know, most oncologists on the continent are clinical oncologists. So we had about 59% of them as clinical oncologists. We had representation from 14 countries in sub-Saharan Africa, and most of them, they practiced in the public health system. Only below half of them were aware of the Choosing Wisely list, which is a call for the task force to increase the awareness, like presenting these findings here. But for those that were able to respond, about 90% of them agreed that the Choosing Wisely list is helpful. I mean, it would be helpful if the Choosing Wisely list is displayed in different clinics on the continent. And generally, the respondents were in agreement with the recommendations, which is a good, thing for us who are involved in this initiative. And the highest agreement among them was that patients should actually be staged before being treated with whether radiation, chemotherapy, or surgery. Proportion of some of them who implemented this recommendation, by the time of the study, a big proportion of them were actually implementing the recommendation, whether they knew about the Choosing Wisely initiative or not, or they were just following the clinical guidelines. But it's good that most of them were actually implementing the recommendation. There was the lowest rates of concordance was related to the shorter schedule of radiotherapy. And this question was about one of the practices that we put there that we feel people should talk about is if a patient has the same outcome in terms of using short course radiotherapy versus long course, which one would you choose? So most of them had lower rates of concordance. So meaning that some of the practitioners are actually giving patients a longer course of radiation, whether it's metastatic or even for diseases like rectal cancers, where we have two options. They're still giving longer courses. So the lesson we learned from this practice, from this exercise, is that while most of the frontline sub-Saharan African oncologists agree with the choosing wisely recommendation, we need to put more efforts in disseminating the list and letting people be aware of the list. The agreement with the recommendation was high, but there was still gaps in terms of implementing these recommendations in practice. So there's one part to agree and agree with the recommendation, but it's also another part of actually putting in and implement this recommendation. And this is where the Choosing Wisely movement is going forward. So we are moving from awareness as we do the awareness, but also trying to find ways how to actually people should implement this recommendation. So we understand there's requirement to now understand what are the barriers and actually implement, enablers of implementing Choosing Wisely on the continent. There are some that we think, and we are actually right now publishing a paper on this, what we think are the barriers and enablers of implementing Choosing Wisely on the continent. But also we are currently also measuring the concordancy now by going to the centers and seeing how actually the Choosing Wisely recommendation are put in practice. So this was our paper at ASCO. Thank you so much.
Thank you, Dr. Fidel, for the wonderful work you're doing with the Choosing Wisely project. And just for the purposes of time, we'll move on to our next presenter, Dr. Tolani. Before we go into, probably we have just 5 minutes for all questions. I've compiled some of the questions for each speaker as they come along in the chat. Thank you.
Good evening, organizers. I don't know if you can assist me to share the slides from the end.
We can't hear you well.
Hello, good evening, everyone.
Yes, much better. Good evening.
I'm Dr. from Zaria, Nigeria. I'm standing in for Musliu Tolani, who is unavoidably absent due to a travel. I'm asking, please, can you help me share the slide from your end? I've sent it to Dr. Fidel.
Oh, thank you. Dr. Fidel, are you able to share Dr. Uma's slides?
Yes, let me do that quickly.
Thank you.
All right. Can you see this?
Yes, it's coming up. Thank you.
Okay.
So our paper was on quality of cancer care in a low resource setting in a single center, Ahmadu Bello University Teaching Hospital, Zaria, Nigeria. It was an observational study, and I was part of the authors. So
sorry to interrupt a bit. Sorry to interrupt a bit, Dr. Uma. If you may just move closer to your microphone, we can't hear you well.
Okay, sorry about that. Are you hearing me now?
Much better, thank you.
Okay, sorry about that. So we all know that in developing countries, access to healthcare is a big challenge. A much bigger challenge is the quality of care these patients receive. Plan and also to achieve quality of care is. So the paper in our teaching hospital in Zaria, Nigeria. This next slide. This was a cross-sectional observational study, and it was conducted within a period from December 2020 to May 2021. We saw the ethical approval of the teaching hospital and the eligibility of patients who had histological diagnosis of cancer, who were either planned for surgery, chemotherapy, or radiotherapy, or they were currently receiving such treatment in the facility. Next slide, please. The a questionnaire was developed in which the demographic and the clinical data of the patients were obtained, and then the quality of care was assessed using consumer assessment of healthcare providers and systems instrument, which had a very good Chromberg alpha score. The quality of care was assessed using 6 composite questions and 2 single-term questions, which were rated in Likert scale. And then 2 further questions on the experiences of patients were measured using an 11-point numerical scale from 0 to 10. In total, 27 questions on the quality of care were asked, and then they were produced under 10 labels. Next slide, please. The analysis was done using statistical package for social sciences version 20.0, and a comparison between 2 groups were made using the student t-test. We had a p-value of 0.05, which was considered to be significant. So the following were the results were obtained. A total of recruited for the study. They had an average age of 60 years, which ranged from 43 to 69 years. And then the males were patients, while the females constituted roughly about 60% of the patient. And the average duration of the patient since diagnosis of cancer was 4 months, which was the median. And then it ranged from 2 to 14 months. So this is the next slide, please, showing the distribution of the cancer patients in the study. Majority, 31% of them were patients who were diagnosed of, sorry, the slide before, not this, gastrointestinal cancer, while 27% had prostate cancer, 24% breast cancer, and then the least were cervical cancer patients. Next slide, please. So these were the summary of the major findings. On this table showed the assessment of the quality of care using 4 tier Likert scale, with the least, which is never, sometimes, then usually, and then always. So the first assessment was receiving timely appointment and care. You could see that
we have lost you, Dr. Umar.
The information used to coordinate. Hello?
Okay, go ahead.
Okay. The information used to coordinate the patient care, you see that majority of them were the usually response, while the office staff being helpful and respectful to patients, see that majority of them were using the response usually and always, while the access to interpreters, see that it was not so good. Lesser number had access to interpreters, or we are satisfied with the access to interpreters. Next slide, please. So the next one was assessment of the quality of care using 3-tier Likert scale, which no, yes, somewhat, and yes, definitely. So you see that the supports to management and cancer effect, you see that there are a lot of patients who did not have the required support. Provide information when needed. See that some significant proportion of patients didn't have this. And also the family and friend involvement in care, you see that this overwhelming majority had family and friend support during treatment. So to measure the patient.
Dr. Umar, I think you're breaking.
Those that had recurrence. Hello? Those that had recurrence had poorer assessment of their cancer care team compared to those who experience of the quality of care by cancer patients. You see that you had a total cumulative score of 7.8 out of a maximum of 10 with a standard deviation of 2.0. And those who had recurrence had a poorer assessment of their overall experience compared to those who did not have recurrence. And this was statistically significant finding. So the conclusion is that the patient's general rating of their experiences with cancer care was good. However, there are gaps that were highlighted, especially in the area of patient support, communication, and navigation. And these suboptimal experiences were more with patients who had recurrence compared to those who didn't have recurrence. And this gap could be further improved to enhance the delivery of cancer care in the limited resource setting. The limitation of this study is that the assessment was done strictly from the patient's perspective, so there could be possibility of exaggeration or under-reporting of some of their experiences. Thank you very much for the opportunity.
Thank you so much, Dr. Umar. So we'll move on to a couple of questions that were posted on the chat briefly for Dr. Umar, our previous presenter. There were questions that were pertaining to comments regarding accessibility of staging investigations in Kenya, particularly PET scan, and availability of palliative care services, including hospice care, and just your general take on the lung cancer status in Kenya.
Great. So yes, so those are great questions, and if I may just go to them quickly. Yeah, so PET scan is available now. There are 3 institutions who offer PET scan services, and that used to be a big problem before, and patients used to actually go all the way to India just to get the PET scan. So we're doing much, much better than where we were before. About lung cancer, probably the uptake in terms of diagnosis might not be very good, but also in terms of epidemiology, I will not be surprised if it's not a very common cancer in this neck of the woods. But there is also a bit of a problem in terms of people trying to focus more on diagnosing TB, pulmonary TB. So the symptoms, as you know, usually do overlap, and there might be actually a lot of cases that are not diagnosed on time, leading to differences in the incidence rates. Thank you, Dr. Nazik and Naomi, for that paper on oncology nursing. I'll look it up. Yes, Professor Nazik, climate change is a big problem, and a lot of people don't really address that part in terms of its role in leading to late presentation and actually a lot of problems in access of care. Specifically in the part of Kenya that I work in, most of the patients are from nomadic background, and due to change in climate change, they do move in search of water and pasture, and compounded by the other effects of climate change. So really a very not that new, but a lot of people are finding it to be new in terms of cancer association. I think my questions are up, right? Hospice care is, we need to really do well. We're not doing very well in terms of palliative care, but we do have a palliative national protocol document, which usually advocates for early implementation of palliative care, really right from the diagnosis to the continuum of the cancer care. but probably we need a lot of specialists as well. We don't have many in terms of palliative care and the hospice care services. I think I'm done with my question.
Thank you. Yes, you have addressed all three. Thank you so much. And thank you to all the presenters for sharing the remarkable work that you're doing in our continent in Africa. So I will just hand over to Nazek to just close off and possibly a couple of wise words. And if there's anybody with any burning question, maybe just one or two for the purposes of time, you can just address them to Nazek. Thank you.
Thank you so much. This has been amazing. And so when we started the session, I have asked that the central question is, when we are participating at ESMO and ASCO and these global platforms, are we active participants presenting the knowledge we have produced, or are we passive consumers of knowledge produced elsewhere? And I have to say, I mean, I got some of the answers here is that we are actually producing excellent knowledge, and it's whole range that I actually like the themes from value to clinical trials and all of that. So I want to thank you so much. And I want to thank Achille and Melinda and Fidel for leading this. I also want to thank the Secretariat for helping to organize this and put it on very quickly. And I also want to say that here at the Education and Training Committee, this will be perhaps the first of such events. We are looking hopefully to do some journal clubs, talk to people who have produced or are in the process of doing educational activities or research. So please contact us. We will be happy to organize events with you. Please also give us suggestions as to what really work for you. Obviously from here, from the questions, obviously not all of them were answered, and there is still some discussion that needs to go on. So hopefully we will continue that. And I look forward to hearing from you, and thank you so much. So I think with that, if anyone has any other questions, or I see Rose is here, so thank you. Rose is the president of AORTIC. Professor Christopher William, one of the founders of AORTIC, was also here. So thank you all for your work. And of course, we asked Miriam, the next AORTIC president, to continue this work as well. So take care. I see a question. I see a hand of Reggie. Is it Reggie or Reggie? I don't know. Their hands were up, but since there is no other question, thank you so much, and we'll see you in the next AORTIC activity.
Sorry, I've just been, somebody just unmuted me. So if you just indulge me for 2 seconds, I have a selfish request. Dr. Williams, and we're nice to see you again. I think if I recollect, the first time I met Dr. Williams, obviously was one of my professors at UCH, but I met him at AORTIC in 2000 in New Orleans. So that was my first attendance. And this is my very first attendance after that time, joining as a member. I have one request to make. The clinical trials going on, if there's any way any person has very keen interest in participating in clinical trials with biopharmaceuticals, I don't know how they can get in contact with me or how I should engage them. I need that kind of information or channel as best as I can. I've been in industry for more than 20 years, and my whole thing is clinical trials. I have never been able to get sites in Africa participate other than South Africa. So this is something dear to me. I lead a lot of clinical programs with big pharma, different companies. And currently I'm really in search of good sites in Africa that really want to participate in clinical trials. I can help build your infrastructure, but you have to come, let's really have a good talk, what is needed. So that's my plea. I just joined. I think my information is with AORTIC. I'm happy to talk to any person, but I need to channel clinical trials to Africa.
Thank you.
That's it.
Thank you so much. So if you share your with your email, and perhaps it can also be sent to all the people who are registered here. So thank you, everybody. I know it's 17 minutes after 6, and this is a Friday, so actually just shows the commitment. Still 50 people are here, and there were 75 before. Oh, I have to give Professor Christopher William, one of our founders, a chance to talk. So Chris, good to see you.
Listen, thank you very much. It's a pleasure indeed to be able to say a few words. I noticed that at the highest point of the meeting, we had about 74 participants at this meeting. This is, to my knowledge, about the best meeting we've ever had by this new method of telecommunication right across the world. I'm speaking to you from the Pacific coast of Canada, where it is now 11:18 a.m. So I'm sure that it's almost late evening for some of you. In any event, I think this has been very, very successful, and I would very much like to thank Professor Hamad for her effort. I would also like to take on my good friend, Dr. Westwood, who I haven't spoken to for about 22 years. So it's been very nice to hear you come up. It's also nice to know that we are now in the pharmaceutical industry. It would interest you to know that for the last 8 years or so, the AORTIC Hematology Oncology Research Group has been looking for a very small amount of money to advance a very innovative treatment program for childhood and young adult acute lymphoblastic leukemia. I will be looking only for about $1 million for the study of about 50 to 100 individuals on this innovative treatment. So it will be very useful if you could finally join us to be able to bring about the realization of this innovative program. As I said, all we need is just $1 million to be able to treat children with a very, very innovative treatment program. You can easily get my email address from the secretariat. I can give it to you right now. It's CW, so C William, no S after the N, at nisa.net. And I'll be very, very happy to be able to communicate with you, and also to be able to get other interested individuals from other parts of Africa to join us. Right now, the study is based in Nigeria, and it's going to look at the effect of multi-center study of this very important disease. Anyway, it's been very nice. And again, I thank everybody who has contributed so significantly to this very successful meeting. Thank you.
Thank you so much. And I wanted to tell you that for our education and training symposium last year, we had more than 100 participants.
There you go. Well,
so we'll try to keep the bar.
I'm a little bit behind. Sorry.
So thank you so much, everyone. We can continue here forever, but I'm cognizant of the fact that this is a Friday evening. So hope to see you soon in other events, and take care.